Hello everyone, how are you all? Sorry for the time confusion today. So actually I was not aware of the time change. So today we are going to do cardiology lecture 2. How did you go with our cardiology lecture 1? Did you finish the chest pain and also the myocardial infarction thing from JM and other stuffs? Those who are in the Facebook, you can always write it in the comment box that if you are having any trouble listening to me or if you have any particular question, you can always write it in the comment and I'll have a look. And those who are in the Zoom, you can write it in the chat box. So today we're going to do the cardiology. Mainly we'll focus on heart failure today. Now, before we start with the heart failure, let's just watch this video first to know that how heart failure can occur. Okay.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Okay, so this is basically what happens in congestive cardiac failure, which means that in heart failure, your heart is unable to pump enough blood to the whole body. So because heart is not pumping enough blood, there will be renal hypoperfusion. And when kidney doesn't get enough blood, it starts to retain fluids mainly. So when kidney start to retain salt and water, your body starts accumulating fluid and there is congestion everywhere in the body. So you can get raised JVP, the lungs can build up with fluids, which we call pulmonary edema. You can develop ascites, you can develop leg edema and all of these features. So let's go into the detail of heart failure. So 60-year-old man presents to your primary care physician for several months of dyspnea on exertion, exercise intolerance, and lower extremity swelling. He has a past medical history of sarcoidosis. On physical exam, he has jugular vein distension and pitting edema in the lower extremities. An echocardiogram shows an ejection fraction of 35%. So you can understand that ejection fraction is a very good method to understand how your heart is functioning. So if the ejection fraction is less than 45%, that means probably you are having heart failure. So all are features of heart failure, as you can see in here: dyspnea on exertion, lower extremity swelling, the raised JVP, pitting edema as well. Now, there are two cases in here. One of them could be right heart failure, another it could be left heart failure. Or you can say systolic heart failure and diastolic heart failure. So heart failure is divided into many parts. As you already can see, there can be right heart failure, left heart failure, and sometimes it could be biventricular failure. Or depending on the functional capacity, We can divide it into systolic heart failure and diastolic heart failure. For the purpose of treatment, systolic versus diastolic heart failure is important to understand because the treatment will be different in these scenarios. So case one, if you see 62-year-old man with a hypertension and dyslipidemia presents with dyspnea and lower extremity edema for 2 months. On exam, there is jugular venous dissension, S3 gallop, and the apical impulse is displaced to the left of the mid-clavicular line. The chest X-ray shows enlarged cardiac silhouette. The echocardiogram shows a dilated left ventricle with an ejection fraction of 35%. Okay, so this is one part in which you can understand patient having raised JVP, patient having S3 gallop, lower extremity edema. Obviously, this is heart failure. In here, you can see that patient's ejection fraction is 35%. In the case two, if you look at here, a 57-year-old having dyspnea and lower extremity edema for 2 months, there is raised JVP, audible S4, but apical impulse is non-displaced. Whereas in here, apical impulse was displaced. There is normal cardiac silhouette. Echo shows a thickened left ventricle with an ejection fraction of 65%. Now, ejection fraction in this case is more than normal. Normally 45 to 55 is okay. 65% is even more than normal. Now, you can see the difference between these two. One of them is systolic heart failure, another is diastolic heart failure. So let's move into detail about this, then you will understand which one is systolic and which one is diastolic. Now, before we move into the subtype, what are the symptoms and signs of heart failure? Someone having heart failure, they will accumulate fluid in the body. So all of the features will be related to fluid accumulation. So patient can develop dyspnea and orthopnea. Orthopnea means that when patient lies down, they feel more short of breath, which is very common presentation for heart failure patient. Patient can have a dry, irritating cough, fatigue, and lethargy. Most of the time, they will gain weight because of fluid accumulation. There will be pitting edema in the ankle. And sometimes patient can come to you with abdominal discomfort because of hepatic congestion. Patient with right heart failure can have hepatomegaly, which is tender. So tender hepatomegaly is one of the features of right heart failure. Second, because of poor cardiac output, because your heart is not pumping enough blood to the body, your brain is not getting enough blood, so you can get dizzy spell or even blackout or syncope. You'll feel weak and fatigued. So what are the difference between left heart failure and right heart failure features? Now look at this image. Now, let's just assume this is not your heart, obviously, but let's just assume this is your heart. Your heart has 4 chambers. This is the aorta, right? And this is the pulmonary trunk. Right? And then say that this is superior vena cava, this is inferior vena cava. So what happened is that blood from superior vena cava and inferior vena cava comes from your whole body, and then it goes to the right atrium, then to the right ventricle. From the right ventricle, blood will move to the pulmonary artery, and pulmonary artery open up in the lungs, right? So pulmonary artery will go to the lungs. And after that, when pulmonary artery takes blood into the lungs, it becomes oxygenated in the lungs, and then oxygenated blood comes out from the lung through the pulmonary vein into your left atrium. So left atrium gets oxygenated blood, and this is your pulmonary vein. Through pulmonary vein, blood comes into the left atrium, go to the left ventricle, and then through the aorta, it goes to the whole body. So this is how the blood circulation happens in our body, right? So most of you know all about this. Now, what happens in these cases? Sometimes it could be the left heart is not working properly or right heart is not working properly. Most of the time, left heart failure happens first, and because left heart is not pumping enough blood, sometimes right heart failure happens as a complication of left heart failure. Okay, now in case of left heart failure, what happens is that, let's say that your heart is not pumping enough blood to the aorta, so there is accumulation of blood in the left ventricle, then there is accumulation of blood in the left atrium, and then there is backward pulling of blood. So pulmonary vein will be congested, and then the lung will get congested with the bloods or fluid. When it happens, your pulmonary edema develops. And when pulmonary edema develops, patient starts to get shortness of breath. Patient gets more shortness of breath when they lie down, which is orthopnea. Sometimes during night, they wake up in the middle of the night and they catch up breath like this. Okay, that is called paroxysmal nocturnal dyspnea. Okay, so patient with left heart failure mainly presents with, their main feature will be dyspnea, orthopnea, paroxysmal nocturnal dyspnea. When you do physical examination, most of the time you will get patient with pulmonary edema will get bilateral basal crepitation. You can get some abnormal heart sound like third heart sound, which we also call gallop rhythm. And sometimes the sort of patient can get tachycardia, tachypnea as well, but not very important to understand. Patient with left heart failure with pulmonary edema can get a pink frothy sputum as well. All right. So what are the main features of left heart failure? Patient develops dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and on sign you will get bilateral basal crepitation, S3 gallop rhythm. Now let's say that lungs are congested and lungs are totally filled with fluid or blood. Then what will happen? Then pulmonary artery will get congested. One time there will be pulmonary hypertension because of excessive blood accumulation in the pulmonary trunk. Then what will happen? Right ventricle will need a lot of pressure to bypass this pulmonary hypertension. So right heart needs to work harder to push blood from right ventricle to the pulmonary artery. At one point of time, right heart will fail. And then right heart fail means blood is collecting in the right ventricle, right atrium, and then it's collecting into all the vena cavas. That's the time you get raised JVP. And due to congestion in the whole other body, you will get hepatomegaly, you will get ascites, you will get bilateral pitting edema in the leg. So these are all features of right heart failure. What are the right heart failure features? Raised JVP, tender hepatomegaly, ascites, and bilateral pitting edema in the ankle or leg. Cool. So that's mainly the features of heart failure that we need to remember. Now, let's go into systolic and diastolic heart failure. Listen to this video.
Heart failure occurs when the heart is unable to provide sufficient blood to meet the body's needs. Heart failure is not a disease on its own, but rather a consequence of other underlying conditions. The impairment of the heart function can be due to an inability to pump effectively during systole, called systolic heart failure, or inability to fill properly during diastole, called diastolic heart failure.
So this is the basic first. So systolic means when systole happens, then your ventricle contracts and it pushes blood out of the heart to the aorta. Now, if this pressure is impaired, that means if the systole or inability to pump the blood out of the heart to the aorta is impaired, that is systolic heart failure. And diastole means that when heart relax to receive blood into the ventricle, that means heart is having diastole. Now, if the heart is having inability to fill up, there's diastolic heart failure.
Heart failure can be right-sided or left-sided, depending on the side that is affected. About 2/3 of all left-sided heart failures are caused by systolic dysfunction. In systolic heart failure, ventricular contraction is compromised. This may be caused by any condition that weakens the heart muscle or creates more difficulty for the ventricle to pump. The most common include coronary artery disease and its consequences. Plaque buildup narrows the coronary artery, reducing blood supply to the heart muscle. Complete blockage can cause heart attacks, which often leave behind non-functional scar tissue. Dilated cardiomyopathy. The ventricular wall is dilated, becomes thin and weak. Hypertension. Higher systemic pressure makes it harder for the ventricle to eject blood. This is because the pressure in the left ventricle must exceed the systemic pressure for the aortic valve to open. Valvular heart disease. Damage to the valves, such as stenosis, also makes it more difficult for the ventricle to pump. The effectiveness of ventricular contraction is measured by the ejection fraction. Typically, the left ventricle is filled with about 100 milliliters of blood, but only 60 milliliters is ejected during contraction. This corresponds to an ejection fraction of 60%. The normal range of the ejection fraction is between 50 and 70%. When ventricular contraction is impaired, the volume of ejected blood is reduced, and so is the value of the ejection fraction. In systolic heart failure, it drops below 40%. In diastolic heart failure, the ventricle is filled with less blood. This may be because it is smaller than usual, or it has lost the ability to relax. The ejection fraction may be normal, but the blood output is reduced. The ejection fraction is therefore commonly used to differentiate between systolic and diastolic dysfunction.
So this is very important. In here, they said ejection fraction normal is 50 to 70, but we will keep it as 45 to 55. Okay. Now, if it is less than 45, that means patient having systolic heart failure. And if it is more than 45, still having features of heart failure, that's diastolic heart failure.
Examples of conditions that can lead to diastolic heart failure include hypertrophic cardiomyopathy. The heart muscle grows thicker than usual, leaving less room for blood filling. Restrictive cardiomyopathy. The heart muscle becomes rigid, unable to stretch. Hypertension can also cause diastolic dysfunction indirectly via compensation mechanisms. As higher systemic pressures make it more difficult for the ventricle to pump, the heart compensates by growing thicker muscle to try harder. Larger muscle means reduced space for blood filling. Regardless of being systolic or diastolic in nature, left-sided heart failures share a common outcome: less blood pumped out from the heart. As a result, blood flows back to the lungs where it came from, causing congestion and increased pulmonary pressure. As this happens, fluid leaks from the blood vessels into the lung tissue, resulting in pulmonary edema, a hallmark of left-sided heart failure. Accumulation of fluid in the alveoli impedes the gas exchange process, resulting in respiratory symptoms such as shortness of breath, which worsens when lying down, and chest crackles. Right-sided heart failure is most commonly caused by left-sided heart failure. This is because the increased pulmonary pressure caused by left-sided heart failure makes it harder for the right ventricle to pump into the pulmonary artery. This results in systolic dysfunction. In compensation, the right ventricle grows thicker to pump harder, which reduces the space available for filling, eventually leading to diastolic dysfunction. Other common causes of right-sided heart failure include chronic lung diseases, which also raise pulmonary blood pressure. As the right ventricle pumps out less blood, the blood again backs up to where it came from, and in this case, the systemic circulation. This results in abnormal fluid accumulation in various organs, most notable in the feet when standing, sacral area when lying down, abdominal cavity, and liver. The fluid status can be assessed by examining the distension level of the
So that's all we have already discussed,
jugular
right?
vein.
So I think it should be clear by this time. So you understand what is systolic heart failure and what is diastolic heart failure. So most common is systolic heart failure because most of the time heart is having this inability to pump enough blood to the body. Because of that, what happens that your heart is not pumping enough blood, so ventricle gets dilated and it contracts poorly. Because ventricle gets dilated, your apex beat can get displaced, and because ventricle is not contracting properly, ejection fraction becomes lower than normal. Whereas diastolic heart failure is normally in diastole, heart should get relaxed to receive blood. Now, because heart is not able to receive enough blood, it is also not able to pump out enough blood. Okay, but in here, the contraction is normal. That means pumping is normal. That's why ejection fraction will be normal. Okay, so diastolic heart failure, the problem is it could be that ventricle size is low, in which like sometimes in hypertrophic cardiomyopathy, heart ventricle and the septum becomes hypertrophic. So the space in the left ventricle becomes very minimal. Okay, so there will be less filling of blood in the ventricle. That can cause diastolic heart failure. So in diastolic heart failure, problem is mainly with the filling of the heart, not with the contraction. So contraction normal, that means patient's ejection fraction is normal. So diastolic heart failure should be suspected in the elderly with hypertension, but in normal heart size on the chest X-ray who present with dyspnea or pulmonary edema. Example of systolic heart failure, you already have got an idea that anything which causes problem in the left heart, so it could be aortic stenosis, hypertension, dilated cardiomyopathy, coronary artery disease, anything can cause systolic heart failure. Whereas diastolic heart failure, it can be due to hypertension, obstructive cardiomyopathy, restrictive cardiomyopathy. And you understand that how to differentiate between these two. The main differentiation is mainly done by echocardiogram. When we do the echocardiogram, it gives the absolute value of ejection fraction. Looking at the ejection fraction, we can say which one is systolic and which one is diastolic. Give it a read about systolic heart failure and diastolic heart failure causes we already discussed. Now, the next one, like let's say, is someone coming to you with features of heart failure, which seems to be acute heart failure, okay, or acute congestive cardiac failure. In acute failure, what is your next test for that particular person? Guys, so in someone coming to you with acute congestive cardiac failure, what's your initial test or what's your next test? see that most of you got it wrong. It's totally wrong. Remember one thing, when a patient presents in the emergency department, mainly with these heart failure features, you will always do baseline ECG first. ECG is must. So electrocardiogram should be your initial test, because this sort of patient can have underlying myocardial infarction causing this heart failure. So if any time in the exam they ask you that what is your next test, your next test should be always first line. This is the bedside test, ECG, right? You have to do ECG. Think you are working as an intern in a hospital. Have you ever seen someone just getting echocardiogram without having a baseline ECG? Never. So in Australia also it doesn't happen. So someone coming in here with heart failure features, you are not just sending the patient with for echocardiogram. It's not a bedside test. So it will take time to get the echocardiogram. So obviously in this case, you have to start with the ECG first. After ECG, then we do the echocardiogram. So the basic thing is that what is the initial test in this patient, or next appropriate test? ECG. What is the most appropriate, or what is the best test, or what is the diagnostic test? That would be your echocardiogram. How about BNP? Do we do BNP to diagnose heart failure? So BNP is B-type natriuretic peptide. This is a kind of hormone which is secrete from ventricular myocardium. Now, my question is, do you do BNP to diagnose heart failure? You don't do BNP to diagnose heart failure. It actually helps with prognosis and severity of heart failure. So once you diagnose a patient with heart failure, then if you want to know that what is the severity of heart failure for this patient, you can do the BNP. So this is not for diagnosis. It's mainly for assessing the prognosis of the patient and severity of the patient. Okay. Now you can do chest X-ray. Chest X-ray, it can show you the features of pulmonary edema, but it's not very, very important. But you have to do ECG, you have to do echocardiogram, that is must. So confirmatory test is echocardiogram, as we know already. So the BNP is almost always elevated in patient with decompensated heart failure. Normal BNP excludes congestive heart failure as the cause of dyspnea. So it's a good test, but not for diagnosis. So we diagnose the patient. Now the treatment. So what's the treatment for heart failure? Treatment of heart failure depends on that, is it a systolic or diastolic heart failure? It's very important to know that is it systolic or diastolic. By the time we do the echocardiogram, we know is it systolic or diastolic. Now, the first line therapy for heart failure, mainly for systolic heart failure patient, is ACE inhibitor. So always remember that you will start with ACE inhibitor first, plus furosemide, plus spironolactone, plus beta blocker, and lastly digoxin. So this is the stepwise addition. So you started with ACE inhibitor, doesn't help, then you give either furosemide or spironolactone, then you add beta blocker, and last option will be digoxin. Okay, so this is the stepwise approach. So ACE inhibitor or ARB plus diuretic. Now diuretic is mainly given when patient having features of congestion, especially not for ankle edema, but for pulmonary edema. So when you see that patients having fluid overload, especially in the lung, we should start with diuretics. When patient becomes stable, then you should start with selective beta blocker. You can also give aldosterone antagonist, which is your spironolactone. Then the last option would be digoxin and vasodilator. Now, beta blocker, there is a very important to understand that when you can start beta blocker in a patient with heart failure. Remember, when heart failure patient is decompensated, that means that patient having severe shortness of breath, acute pulmonary edema, that time you should not start beta blocker because it can make it worse. Why it can make it worse? Because beta blocker can reduce the heart rate, and then if heart rate is reduced, on like heart is not pumping enough blood, and if the heart rate is reduced, that means it will worsen the heart failure more than ever. So when the heart failure becomes stable, that means you started with ACE inhibitor, furosemide, spironolactone, and now the patient's shortness of breath is all gone. Patient is stable. In chronic heart failure, beta blocker is a very, very good one because it can reduce mortality, it can reduce hospitalization, it can even improve ejection fraction. So beta, sorry, someone's microphone is on, I think. Okay, sorry. So start patient on beta blocker after stabilization of symptom with diuretic and ACE inhibitor, irrespective of blood pressure status. Remember, beta blocker doesn't affect blood pressure too much, so don't worry with the blood pressure. Usual beta blocker that you use is either carvedilol or metoprolol or bisoprolol. So it's a selective beta blocker. You are not going to start propranolol in this patient. Okay, so carvedilol, metoprolol, atenolol, bisoprolol, this is what we can start. So it's very important and it comes in the exam. So now you understand the systolic heart failure. If the patient is not having pulmonary edema, you can start with ACE inhibitor and then gradually you can add up. So you can add furosemide or spironolactone. Then when the patient becomes stable, start with beta blocker, and last option will be digoxin. Digoxin no longer first line management. It was used before, but try not to use digoxin if you don't need it. Only digoxin is used nowadays if someone having atrial fibrillation and that's causing heart failure. There is an indication of using digoxin, but again, it's not the first line. Someone having chronic heart failure with atrial fibrillation, your management should start with beta blocker like metoprolol. But someone having acute decompensated heart failure due to atrial fibrillation, then you can use digoxin. I know this is a lot of things to take in, but these are important information. Now, for diastolic heart failure, management mainly based on treating the underlying cause like hypertension, diabetes, etc. The basic treatment in this case should be started with a calcium channel blocker and a beta blocker. Why? In diastolic heart failure, your heart is not filling up, right? So if your heart is not filling up, you should make the heart fill up. How you can make the heart to do that? You can reduce the heart pumping. Like if you reduce the contraction of the heart, then heart will get enough time to fill in. So what are the agents that reduce your heart rate or your heart pumping? So mainly two, beta blocker and calcium channel blocker. Mainly the rate limiting calcium channel blocker. What are those? Verapamil or diltiazem. And you can use beta blocker as well. Now in this case, try not to use diuretics, try not to use digoxin or even any vasodilators. Why? Because your heart is not getting enough blood to fill in. If you give diuretics, it will Like it will reduce the volume of the body more, right? If you're if the volume of the blood is low in the body, obviously it will make things worse, right? Right now, heart is not filling in. And if with like you should help the heart to fill in, but on the contrary, if you are using diuretics, diuretics will excrete or reduce blood volume. So your heart will not get enough blood to fill in. So that's why avoid diuretics, avoid digoxin for the same reason. Vasodilators, nitrates, so all are same reason. Vasodilators causes peripheral pooling of the blood. So again, heart will not get enough blood to fill in. Okay, so in case of diastolic heart failure, your first line management will be a calcium channel blocker and beta blocker. Now, sometimes they ask in the exam that which medication does not improve with survival in congestive cardiac failure. These are the three drugs which improve mortality in heart failure patient. So ACE inhibitor, beta blocker, and spironolactone. All other drugs doesn't improve survival. So furosemide doesn't help. Remember that. Calcium channel blocker doesn't improve survival. Only these three improve survival. So if we just recapitulate what we have understand from heart failure chapter, that echocardiogram is the gold standard to diagnose heart failure. ACE inhibitor, if tolerated, recommended for all patients with heart failure, especially it's recommended for systolic heart failure. The primary reason for prescribing an ACE inhibitor is to reduce the risk of death. So it improves mortality. Diuretics should not be used as a monotherapy in case of heart failure patient. It should always use in combination with an ACE inhibitor. Be aware of hyperkalemia, because if you give ACE inhibitor with a spironolactone, it can cause hyperkalemia. Okay. So we already discussed about how congestive cardiac failure can present and all these things. Now, come to the drugs and their side effects. It's very important to know the side effects of these drugs because it comes very commonly in the exam. So we use thiazide diuretics. Mainly we use hydrochlorothiazide. Also we use indapamide, which more or less acts like a thiazide. So what are the common side effects of thiazide? It can cause hyponatremia, hypokalemia, but it can cause hypercalcemia and hyperuricemia, which means this hyperuricemia can precipitate gout. So someone having gout, you should not start thiazides for them. It also can cause glucose intolerance or hyperglycemia. So someone having diabetes, it's not a good drug to use. Okay. Indapamide also causes hyponatremia. It's very, very commonly asked in the exam. So some like 60-year-old patient, sudden onset of confusion. Okay. Recently started with some of their blood pressure medication. One of them is indapamide. So what's the cause? Hyponatremia caused by indapamide. Okay. So it's very important to remember that. Thiazides also causes hyperlipidemia or dyslipidemia. Loop diuretics, which is more used in heart failure patient, so furosemide, bumetanide. Loop diuretics also causes hyponatremia, hypokalemia, but it causes hypocalcemia, not hyper. It can cause hyperuricemia. Furosemide can cause ototoxicity, which is very important side effects to know. Spironolactone it causes hyperkalemia and gynecomastia. Very important that in the exam, if you see that someone presenting to you, especially a male presenting to you with gynecomastia, and if you look at the medication, you find out there is spironolactone, there is digoxin, there is other medication. Spironolactone is the most common cause of gynecomastia. So remember that. Now come to the digoxin. Remember, digoxin doesn't improve survival in heart failure patient. How digoxin works for heart failure? So in your cell, you have sodium potassium ATPase pump. Now digoxin inhibit this pump, which results in increased intracellular concentration of sodium and decreased exchange of intracellular calcium. So what happens in here, let's say this is your cell and that is the interstitium or outside the cell. Okay. Now in here there is sodium potassium ATPase pump. This pump helps in movement of sodium outside the cell. So sodium should go out. And sorry. So in your cell, there is sodium potassium ATPase pump. This sodium potassium ATPase pump, if the digoxin inhibit this pump, what will happen that sodium will be increased in the cell. So there will be increased intracellular sodium. And there will be decreased exchange of intracellular calcium for extracellular sodium. So what will happen that normally when sodium goes out, there will be exchange of calcium. So let's say that sodium potassium pump helps sodium to go out of the cell and potassium in the cell. When sodium is outside the cell, there will be an exchange between sodium and calcium. Now, if sodium is not going outside the cell, this sodium calcium exchange is not happening. So there will be increased intracellular calcium. Now, this increased intracellular calcium causes increased cardiac contractility. Okay, so this is how digoxin works. So digoxin increases the contractility of the heart or myocardium. Now, why I have discussed that, there is a reason. Potassium and digoxin compete for myocardium binding site. So again, this sodium potassium pump, right? Now, there is a receptor in the cell. Potassium binds with this receptor to go into the cell. Now, digoxin competes with this potassium to bind with this receptor to go into the cell. Okay. Now, what will happen if in your body there is increased potassium? Potassium will saturate this receptor and digoxin will not be able to bind here. So there will be decreased digoxin activity. That means hyperkalemia will reduce the activity or effectivity of digoxin. On the contrary, if your body gets rid of potassium, so there is hypokalemia, that time digoxin will win the race and digoxin will bind more to the receptor and it will cause digoxin toxicity. So you have to remember this line: hypokalemia results in digoxin toxicity, hyperkalemia results in reduced digoxin activity. Does this make sense, guys? I know this is a lot of thing, but sometimes it can come in the exam and you need to understand it. Is this clear? So what are the conditions which can increase digoxin toxicity? So hypokalemia can cause it. Sometimes digoxin is excreted by kidney. So if your kidney is not working properly, then there will be digoxin toxicity. Advanced age, hypothyroidism, this can cause digoxin toxicity. So Dr. Tithi, I said in here that in your cell, there is a receptor for binding potassium. So this is the receptor. Now, potassium bind to this receptor to go into the cell. Just like same, digoxin also needs the same receptor to go into the cell. So it competes with the potassium to bind with this receptor. Now, in a race, who will win? So if your body has more potassium, it will win the race and it will bind with this receptor. So digoxin will not be able to bind. So there will be reduced activity of the digoxin. Whereas if your body has low potassium, so digoxin will win this race and more digoxin will bind to this receptor, right? And when more digoxin bind to this receptor, there is increased risk of toxicity. Some of the other drug can also increase the risk of digoxin toxicity. So quinidine, calcium channel blocker, spironolactone, thiazides, furosemide, they all can increase the effect of digoxin. So remember this drug. What are the effects or what are the signs of digoxin toxicity? The most common feature of digoxin toxicity is nausea, vomiting. And then it could be gynecomastia, blurry vision, yellow halo around the objects. Digoxin toxicity can cause every arrhythmia that you know. But most commonly, it causes premature ventricular complex. That means all the ectopic beats. It causes bradycardia. It causes paroxysmal atrial tachycardia. Okay, sometimes it can even precipitate heart block. So how you treat digoxin toxicity? So you look for digoxin level. Sometimes even digoxin level can be normal in toxicity. So digoxin level cannot help you to diagnose toxicity. But normally you would check that. Whatever it is, if there is sign of digoxin toxicity is there, you have to stop digoxin. And if you see that patient is having severe symptoms, then you have to give some antagonist. What is the antagonist for digoxin? It is called digibind. So you can give digibind to reduce the effect of digoxin. Clear? Now, very quickly, we will finish the heart failure. There is some medical device which we can use in patients to improve their survival. One of them is very important to know is AICD. What is AICD? It's an automatic implantable cardioverter defibrillator. Only time you use is if a patient having ischemic dilated cardiomyopathy. Because in dilated cardiomyopathy, patients usually die because of congestive cardiac failure and arrhythmia. You put this device which will interrupt the arrhythmia. So what happens in this implantable cardioverter defibrillator, whenever you go into the arrhythmia like VTBF, this will give you a shock and revert you to a normal sinus rhythm. Okay, so only time you use AICD is someone having dilated cardiomyopathy with a ejection fraction less than 35%. Now to come to the pulmonary edema. Pulmonary edema is a medical emergency because patient will present to you with acute shortness of breath. And if you look at the X-ray, you can see there will be bilateral bat wing appearance. See the bat wing? And you can see that in here, the heart shadow is dilated also. So that is your pulmonary edema. It's very important to start furosemide spironolactone in this patient. So this is the bat wing appearance in case of pulmonary edema. And you know that pulmonary edema patient will present with dyspnea. Patient will also have bilateral basal crepitation. They can have a pink frothy sputum. What is the treatment? Treatment is mainly resuscitate this patient. So most of these patients will need oxygen. So give oxygen if needed. Start with diuretics to reduce the preload. Okay, or that means to reduce the fluid in the body. This sort of patient will have severe anxiety, which will worsen the heart failure. So sometimes you can use morphine for that. You need to like position the patient upright. You can give nitroglycerin to reduce the preload. You can give digoxin if the patient is in high atrial fibrillation. The main treatment is mainly upright the patient, oxygen if needed, and start diuretics. Okay. So that was mainly all our heart failure things. Do you guys have any question? So we'll take a 10-minute break now, and then we will start with the other things. So we will start with the murmur. So 10-minute break. Thank you all. All right, guys, let's start again. Now, we're going to start the valvular heart disease now. Now, valvular heart disease, mainly what you need to learn about is that how to get the murmur. Just give me 1 second. I'll see my Facebook people. Cool. So in valvular heart disease, main thing is murmur, because murmur comes in the exam very, very frequently. Now, remembering the type of murmur and site of murmur, characteristics of the murmur is very, very hard, but still you have to do it. Now, for the purpose of the exam, the more important one you will just learn about, which is mainly aortic valve murmur and mitral valve murmur. These two are more important. You don't need to bother about pulmonary murmur or tricuspid murmurs. Okay. Now, I'll show you one of the very easy way to remember this thing. I hope that you guys like it. Now, let's start with one murmur first, which is mitral stenosis. Mitral stenosis is the commonest murmur, right? And common, like more common for which group of population, guys? Mitral stenosis. Good, Dr. Voishi. Yeah, Aboriginal and Torres Strait Islander. Good. Okay, so they are more prone to develop rheumatic heart disease, and rheumatic heart disease are more prone to cause mitral stenosis. Okay, now mitral stenosis murmur is mid diastolic murmur, MDM. Okay, mitral murmur are always at the fifth intercostal space, which is your apex. So left fifth intercostal space. Okay. Now, what is the opposite of mitral stenosis? Opposite, I mean that mitral is opposite to aortic. Okay. In this way, just remember it. What is the opposite of mitral? Aortic. And what is the opposite of stenosis? Regurgitation. Now, aortic regurgitation also causes diastolic murmur. What type of diastolic murmur it causes? Early diastolic murmur. Now, aortic regurgitation murmur, it is best heard at the left fourth intercostal space along the sternal border. Although this is not the aortic area. Now, before we discuss this site, it's a good idea to just to know that what is the site. Let's say this is your sternum. And this is the left side. This is the right side. Let's say this is the right second intercostal space. This is the left second intercostal space. This is the fourth intercostal space. And this is the fifth intercostal space. Okay. Now, this second intercostal space in the left side, it's for pulmonary artery. That means any pulmonary problem or any pulmonary murmur you will get in the left side. Although you might think that left side should be aortic. No, this is where you get confused. What happens is that when you look at your heart, this is your left ventricle, right? Aorta actually goes like this. So your most of the aortic murmur you get in here, which is your right second intercostal space. And pulmonary artery goes like this. So that's why pulmonary murmur, you get it more in the second left intercostal space. Clear? Now, come to the point. Mitral stenosis murmur, you will get in the left fifth intercostal space. Aortic regurgitation murmur, you will get in the left fourth intercostal space along the sternal border, although aortic murmur is more common in this area. But aortic regurgitation is an exception. You need to remember that. There is no way I can make you remember it. At least you will know the diastolic or systolic murmur by this rule. Now come to the other two murmur. What are left from mitral stenosis? What is the other part of mitral stenosis? Mitral regurgitation. And what is left from aortic regurgitation? Aortic stenosis. These two are systolic murmur. Aortic stenosis murmur is ejection systolic murmur, and mitral regurgitation murmur is the pansystolic or hollow systolic murmur. Both of these murmur radiates. Aortic stenosis murmur radiates to the neck. Mitral regurgitation murmur radiates to the axilla. Now, this murmur, aortic stenosis murmur, is, you will find it in here. That means right second intercostal space. And mitral murmur, always you get it in the apex, so it's same. So how do you feel? Like, see that if you only know mitral stenosis murmur, then from just one murmur, you can actually find out all this murmur. Now you don't need to memorize it. You just remember one murmur, and all other murmur, you will, like, it will come as a calculation, right? So this is how I used to remember murmur. And I hope that you guys, now at least you can exclude most of the option. So let's just go into the detail of this murmur. Aortic stenosis murmur is a crescendo decrescendo murmur, which is ejection systolic in the right second intercostal space. Mitral regurgitation is the hollow systolic murmur as the apex radiate to the axilla. We just discussed these two. Aortic regurgitation, it's an early diastolic murmur at the left sternal border, which is at the left fourth sternal border. Mitral stenosis murmur is a mid diastolic murmur, which is a kind of rumbling, best heard on the apex. Mitral prolapse is a systolic murmur with a click. Okay, you just need to remember this murmur. You don't need to remember other murmur. It's not very, very important. Now, if we go to the other one, if you want to know a little bit more about all other murmur, go to these med bullets. If you go to the med bullet, you will see all the murmur pretty well written in here. So systolic murmur, diastolic murmur, you can find it out easily. Now, one of the things I wanted you to know, hypertrophic cardiomyopathy, the murmur is pretty same like aortic stenosis. It's a crescendo decrescendo systolic murmur. Okay, but it's more commonly, you will find it out in the like left sternal border, in the fourth sternal border. Okay, not at the site of aortic stenosis. So go through this guideline, made bullets. Both of these has all the murmurs well written if you have any difficulty to understand it. But you need to memorize these murmurs. It's important, it comes in the exam. Good. Next, we're moving into the cardiomyopathies. There are three types of cardiomyopathy. One is dilated cardiomyopathy, restrictive cardiomyopathy, another is hypertrophic obstructive cardiomyopathy. Hukam. Cardiomyopathy means it's problem with the myocardium of the heart, especially problem with the myocardial contraction. In dilated cardiomyopathy, your left ventricle becomes dilated. So let's see in here, this is the normal heart. Left ventricle, it's little thick because it needs to pump out blood. In dilated cardiomyopathy, what happens that this left ventricle is more thinner than normal. Because of that, it cannot pump out enough blood. If it cannot pump out enough blood, what type of heart failure it can cause? Guys? Cannot pump out. Pumping is done by systolic. So systolic heart failure. Good. What is the most common cause of dilated cardiomyopathy? Idiopathic. Okay, that means no known cause actually. But next is alcoholic. Alcoholism very commonly causes dilated cardiomyopathy. Other than this, you don't need to memorize anything else. Patient with dilated cardiomyopathy presents with heart failure features. So how to treat this patient? You treat similar to the systolic heart failure, which means ACE inhibitor, diuretics, and beta blocker. This patient might be a candidate to get this Aicd if their ejection fraction is less than 35%. Next is hypertrophic obstructive cardiomyopathy. Very favorite topic for AMC. Okay, many cases comes from here. Now, hypertrophic obstructive cardiopathy, the name implies everything in here. So what happens in here? The left ventricle with interventricular septum becomes hypertrophied. So its main hallmark of this disease is that there will be thickening of the interventricular septum. So if you look at here, what do you find out? This is normal left ventricle. Now look at the hypertrophied left ventricular septum. So actually left ventricular muscles and also the interventricular septum gets hypertrophied. So what happened in here, you can see because of the hypertrophy, the size of the left ventricle gets below normal. So there will be lack of filling of the blood in the heart or in the left ventricle. So what type of heart failure you will get here? Diastolic heart failure. Very good, Dr. Kallal, Dr. Rebecca, Dr. Bashar. So very good, guys. So you can see in here, on the top of that, sometimes this hypertrophy, it can obstruct the flow of blood from your left ventricle to the aorta. Okay, now let's see. This HOCM is a autosomal dominant disorder. In 60% case, it can be hereditary. So most of the time, you can also find out there is a sudden cardiac death in the family, which is a very important clue for the diagnosis of this condition. So pathophysiology is as a result of the hypertrophy, left ventricular compliance is reduced, but systolic performance is not depressed. Diastolic dysfunction is the characteristic. In this case, heart becomes hypercontractile. Why? Because like there is a lot of muscle in the body, right? So heart becomes powerful, heart becomes hypercontractile, and because of that, systole occurs with striking rapidity. Because of this hypercontractility, sometimes you can get a finding which is called this large jugular A wave with a bifid carotid pulse. Ejection fraction will be above normal in this case because there is like hypercontractility. So that's why you can get ejection fraction are often 80 to 90%. Okay. And sometimes, as I said, that left ventricle or aortic opening can get obstructed because of this hypertrophy. Sudden death can be a first manifestation in some of these cases. Other than these features, patient with HOCM can get heart failure features. So patient can get dyspnea, syncope, even angina. Patient can have S4 gallop, systolic murmur, sometimes even mitral regurgitation murmur. Now, come to the main thing. So you found a patient who was like a 15-year-old patient presenting to the emergency department because he had a syncope when playing with his friends in the field. There is a sudden cardiac death history in the family. Most likely, this is HOCM. Why? Because during exertion, this becomes more problematic because when you do exertion, your heart needs more blood. But in here, what is happening? Heart is unable to fill in, and also there is obstruction for the outflow. So usually during exertion, your brain doesn't get enough blood and you get syncope. So that's why hypertrophic cardiomyopathy patient can present initially with a syncope or blackout. Now, initially, as the next investigation, you should always start with ECG in this case. Remember, this is very important. It comes in exam. So initially, our next investigation is ECG. In ECG, you might not get anything, but still you have to do it. You can find out left ventricular hypertrophy sometimes. What is diagnostic echocardiogram? Now, sometimes resting echocardiogram may not find out anything. If it's not very serious one, sometimes resting ECG, resting echo will be normal. In the question, if they say that resting echo normal, then they can ask you what is the next one you will do. Then you will choose a stress echo. In a stress echo, you are asking the patient to run on the treadmill, remember? And then during exertion, you can find out who come. Okay, so that's the stepwise investigation for this patient. Now, treatment, because it causes diastolic heart failure, you have to give the heart time to fill in. So what we give? Beta blocker, we can give calcium channel blocker. These two is the main treatment. Now again, because in this case, because your heart is not getting enough blood, so you cannot give anything which reduce blood volume. Like you should not give digoxin, diuretics, vasodilators. So avoid this in a patient with HOCM. Clear, guys? So that's your HOCM. It's very important. Remember it. Next is restrictive cardiomyopathy. Restrictive cardiomyopathy is the least common cause of cardiomyopathy. It means that the myocardium or the left ventricle becomes rigid. Normal heart, or normally the ventricle usually stress or relax. But in restrictive cardiomyopathy, this ventricular wall becomes rigid and stiff, so it doesn't relax. If it doesn't relax, what type of heart failure will occur? Diastolic heart failure. So you guys are getting it, right? So very, very good. So in this case, also patient develops diastolic heart failure. Sometimes this patient can get systolic dysfunction, but the main problem happens is the diastolic feeling. So this patient also can comes to you with the diastolic heart failure features. Common causes of restrictive cardiomyopathy is infiltration. So sarcoidosis, amyloidosis, hemochromatosis, neoplasia, okay, scleroderma, radiation. Treatment, there is no good treatment. Ultimately, it results in death from congestive cardiac failure or arrhythmia. The only treatment that can be effective is heart transplantation. But if there is heart failure, you can treat it as a diastolic heart failure. It's a very bad diagnosis. Okay, most of the patient usually dies. Cool. So that finish our all the cardiomyopathies. Next, come to the pericarditis, which is very important for your exam. Pericarditis comes most of the time acutely, which means patient will present to you similar to heart attack or myocardial infarction. Like patient presents to you with a left-sided chest pain, which usually get worse with lying down, sometimes coughing or deep breathing, and gets relieved by leaning forward or sitting up. There can be a recent viral flu-like illness, which is the most common cause of acute pericarditis. When you auscultate the heart, you can get pericardial friction rub. Okay. What are the other differential diagnoses or causes of pericarditis? It can be any connective tissue disease, could be a metabolic disorder. Most of the time, also you should consider any cancer. Sometimes renal failure resulting in excessive uric acid or like having uremia, the waste product can get infiltrated in the pericardium, causing uremic pericarditis. Okay, so these are the main feature. And if you do the ECG, you will get diffuse ST segment elevation. We discussed it, I think, in the chest pain class, right? So that's your pericarditis. In pericarditis, always start with ECG first. You don't need to do anything else. Most of the time, only thing that you need to do is treat the patient with analgesia. So you can start with aspirin, paracetamol. That's not helping. You can give NSAID. Last option will be a steroid. Okay. Now, pericardial effusion. Pericardial effusion is similar to pleural effusion. Now, what will happen? There will be collection of fluid in the pericardial cavity. Now, let's say this is your heart, and this is your pericardium. Normally, in here, there should not be anything. When there is fluid accumulation in the pericardial cavity, that means pericardial effusion. Now, the fluid can be transudative or exudative. If you get a transudative fluid accumulation, most likely that could be any of the failure. So heart failure, maybe kidney failure, liver failure, sometimes could be related to hypoproteinemia or overhydration. If you get a frank blood in the pericardial space, that could be aortic dissection. If you get serosanguinous fluid, most likely either TB or cancer. It's not very important for your exam, so I'm not giving much time in these cases. So you can see I'm just touching these things. It's not very important. Pericardial effusion. Sometimes can get massive accumulation in the pericardium that it starts to compress the heart. So when it starts to compress the heart cannot fill properly, right? So same like lung, like pleural effusion, same thing happens with pericardial effusion. This fluid becomes over accumulated and start to compress the heart. So heart cannot fill in properly, resulting in heart failure. There is a specific name for that. What is it called, guys? Yes, cardiac tamponade. Okay, so that is known as cardiac tamponade. So if you want to diagnose pericardial effusion, you have to do an echocardiogram. If you look at here, you can see this, like you can see a massive heart. So that's how pericardial effusion looks like. Chest X-ray may show a water bottle configuration of the cardiac silhouette. So it's a water bottle configuration, right? Now, pericardial effusion is not too much concerning until it becomes cardiac tamponade. Because cardiac tamponade is a life-threatening complication in which heart cannot fill in properly because it's compressing the heart. So patient with pericardial effusion complicated with cardiac tamponade starts to have dyspnea, orthopnea. Sometimes patient can develop all the heart failure feature, but important clue in the exam is that you will get a muffled heart sound. So decreased heart sound because heart is not able to fill in properly. So superior vena cava, inferior vena cava, they cannot give blood to the right atrium. So you get all like accumulation of blood everywhere again. So you get distended neck vein, so raised JVP. You get low blood pressure also because the heart is not pumping enough blood. And you can get into hypovolemic shock or cardiogenic shock. One of the other features is called pulsus paradoxus, which is characterized by decrease in systolic blood pressure more than 10 millimeter with normal inspiration. It's not diagnostic, but you can just remember during inspiration, blood pressure, systolic blood pressure should not be decreased. But in here, during inspiration, systolic blood pressure decreased by more than 10 millimeter, that is pulsus paradoxus. Only thing that you need to remember is Bex Triad. So if you find muffled heart sound, the raised JVP, low blood pressure, and patient having dyspnea, shortness of breath, orthopnea, fatigue, you should think about cardiac tamponade. Do a bedside echocardiogram and immediately do pericardiocentesis, which means insert a needle in the pericardium and aspirate the blood or fluid. So that's your cardiac tamponade. Next, constrictive pericarditis. Constrictive pericarditis means the pericardium will get diffusely thickened in response to any previous inflammation. Now, if the pericardium is thickened, heart will be unable to distend properly. So obviously, like let's say, when heart is having diastole, it needs to relax. When it relaxes, also pericardium relax. But if the pericardium is no longer relaxing, heart will not be able to relax properly. Okay, so in this case, again, the same thing will happen, abnormal diastolic feeling. So diastolic heart failure is the main feature of constrictive pericarditis. So this patient also can have like reduced cardiac output, orthopnea, dyspnea. Patient can have all the features of heart failure like ascites, hepatomegaly. Patient can develop JVP raised. All these features are same. Now, constrictive pericarditis, there is a specific sign in X-ray, which is eggshell appearance of the cardiac silhouette. Normally, your heart doesn't have this border. You can see a border in here. Okay, this is actually calcification of the pericardium. Okay, that's why it's called eggshell appearance. It's only present in constrictive pericarditis. Treatment is same for diastolic heart failure. So guys, are you clear with pericardial effusion, cardiac tamponade, and also constrictive pericarditis? Any questions so far? I understand it's a lot of things to take in one class, but I'm really sorry you have to finish cardiology today, unfortunately. Good. You guys are doing really great. Now, next topic is from JM, 7th edition, chapter 86, hypertension. So we finished heart failure, we finished other causes like valvular heart diseases, we finished all the unimportant things like not too much important, cardiomyopathy, and also these tamponade. These are not important for the exam, but still you should have an idea. But hypertension is important. It's not very hard topic. You already know what is hypertension and most of it, but we'll just go through the jam. Now for hypertension, the recommendation of checking blood pressure is every patient starting from 18 years, it is recommended to do 2 yearly blood pressure checkup. This is RSCGP screening guideline. What is the normal blood pressure? Normal is 120 to 129, 80 to 84. Or for your better understanding, just keep it below 140 by 90 is normal. Hypertension can be mild, moderate, or severe. So mild is 140 to 159 systolic, 90 to 99 diastolic, 160 to 179 systolic is moderate, 100 to 109 is diastolic. When it becomes more than 180 by 110, it's severe. There is also isolated systolic hypertension in which diastolic blood pressure is normal, but systolic blood pressure is more than 140. Okay, now, what are the causes of hypertension? 95% cases, there is no underlying cause, which we call essential hypertension. 5 to 10% can have some underlying cause, And it's very important to find that out because you can treat hypertension if you find out any underlying cause. So it could be kidney related, it could be glomerulonephritis, could be renal artery stenosis. Sometimes it could be polycystic kidney disease as well. Endocrine related, so Cushing syndrome, Conn's syndrome, pheochromocytoma can cause it. Oral contraceptives can cause it. Coarctation of aorta can cause it. Polyarteritis nodosa can cause it. Drugs is very important, NSAID, steroids. Sometimes pregnancy can cause it. Very important to know the clinical features related to each of these diagnoses. So in case of renal artery stenosis, you will look for any renal bruit. For glomerulonephritis, we look for hematuria, we look for proteinuria, and RBC cast. Polycystic kidney disease, most of the time there will be a family history positive. You can get bilateral kidney mass with hematuria. Coarctation of aorta. In coarctation of aorta, so this is your aorta, right? And this is the left subclavian artery. Just distal to the subclavian artery, the aorta can get very narrowed. Like in here, aorta gets narrowed, which we call coarctation of aorta. In coarctation of aorta, you will get delayed femoral pulse, which we call radiofemoral delay. And also you can get difference of systolic blood pressure in both arms. Obstructive sleep apnea is a very common cause of hypertension in middle-aged to elderly patient. So obstructive sleep apnea will present like an obese patient coming with snoring at night and daytime sleepiness. In pheochromocytoma, patient present with episodic flushing, headache, sweating, palpitation with hypertension. Pheochromocytoma is a tumor of the adrenal medulla. So these are mainly the important findings which will help you to diagnose the condition or underlying cause of hypertension. So you can find it here. If you get an epigastric bruit or renal bruit, then we think about renal artery stenosis. If we get abdominal flank mass, we think about polycystic kidney. If we get delayed or absent femoral pulse, coarctation of aorta. If we get truncal obesity with pigmented stria, Cushing syndrome. So all are important findings. We should always look into that. There are two other things called malignant hypertension and refractory hypertension. Malignant hypertension means when diastolic blood pressure becomes more than 120 and there is exudative vasculopathy in the retinal and kidney circulation, which means there is end organ damage. So it involves your eye, it involves the kidney. So diastolic blood pressure more than 120 with end organ damage, malignant hypertension. What is refractory hypertension? You have tried maximum doses of 2 drugs for 3 or 4 months, but still there is high blood pressure. That's refractory hypertension. So maximum dose of 2 drugs. Come to the renal artery stenosis. Renal artery stenosis, most common cause of renal artery stenosis is the atherosclerosis. But if a young female coming to you with hypertension and you have got renal bruit, most likely it's not atherosclerosis, it's fibromuscular dysplasia. Initial investigation for renal artery stenosis, you can check plasma renin activity. Plasma renin activity is usually elevated in case of renal artery stenosis. And diagnostic is the Doppler ultrasound of the renal artery. Now, hypertension, how you detect hypertension in a patient. Can you diagnose someone as hypertensive with just single visit or single time patients having high blood pressure? No. If you get an initial raised blood pressure, you should confirm it at least 2 other visits within the space of 3 months. So within the next 3 months, you should find out that if this patient having two other increased blood pressure, only then you can say that this patient having hypertension. So how we follow up or how we manage this hypertensive patient? If it is less than 120/80, you can recheck every 2 yearly. If it is high normal, so 120 to 130, 80 to 89, then you just recheck yearly with lifestyle advice. Grade 1 hypertension, you have to confirm it within 2 months and also give lifestyle advice. No medication is needed initially, okay? If it is grade 2, which is 160 to 179, 100 to 109, evaluate the patient within 1 month again, see is it persistent high blood pressure or not, and also give lifestyle advice. In case it becomes more than 180 or more than 110, you can start treatment immediately. Okay, you can do two things. You can evaluate the patient within 1 week, or you can immediately start medication. I would say start medication. So you understand in here that it's not mandatory to start medication immediately you find out high blood pressure. This is a very common mistake we do. So someone having 160/100 blood pressure, you just start medication. No, you need to at least confirm it within next 1 month, give lifestyle advice, it's still not helping, then you can start treatment. So if mild hypertension is found, repeat measurement over 3 to 6 months should be followed before beginning therapy. But if you get initial diastolic blood pressure more than 115 or more, you can't wait. You have to start drug therapy immediately because they are having more risk of organ damage. Okay, so this is how you start treatment in hypertensive patient. There is a term called ambulatory 24-hour BP monitoring, very commonly asked in the exam. Now, what happened that many patients, they have this high variability of their blood pressure. So today you have found out patient blood pressure is 160/100, and just in 1 month later, you find out it's 120/80. So you can see there is a high variability between blood pressure, right? That time you can do a ambulatory 24-hour blood pressure monitoring. which means patient will do his own job, usual job, and a blood pressure monitoring device will be attached to the patient, and it will collect every hourly that what is the blood pressure of this patient. Depending on that, we can see if there is any other thing which can increase this blood pressure, or like how is the average blood pressure for this patient. Now, not every patient will get it. What are the guidelines of using ambulatory BP monitoring? If you get unusual variability of the blood pressure, just like I said, marked discrepancy between office and home BP. Some patients get high blood pressure in clinic. This is called white coat hypertension. So for those, you can use this. Resistant to drug treatment, suspected sleep apnea patient, and when two BP readings more than 140/90. Mainly, we use this if there is unusual variation between office BP and home BP, and also unusual variability of repeated office BP. Now let's go into the detailed management part, which is important for your exam. If you find out if the average diastolic BP at the initial visit is 90 to 100, no evidence of end organ damage, non-pharmacological therapy is indicated for 3-month period without use of antihypertensive. But diastolic BP more than 115, you should start treatment immediately. What are the conservative management for hypertension? The most important is weight reduction. Remember that it comes very frequently in exam. If you lose 1 kilo of body weight, blood pressure can drop by 2.5 millimeter mercury of systolic and 1.5 millimeter of diastolic. So that's the most important behavioral management. Other than this, reduction of alcohol, reduction of sodium or salt intake, exercise, reduction of stress, smoking, management of sleep apnea. Now, many of you will choose smoking, but don't choose smoking. Choose weight reduction as the most important one. Now, in case of starting blood pressure medication, we always do 5-yearly absolute cardiovascular risk assessment. We haven't done this, I think, right? How to check this cardiovascular risk assessment? Have we? I don't think so. So this 5-yearly absolute cardiovascular risk, there is a chart for that which comes frequently in the exam and is very important. We'll discuss it in any other class. Now, 5-yearly absolute cardiovascular risk gives what is the risk of this patient to have a serious related complication in the next 5 years. So it could be low risk, 10%, moderate risk is 10 to 15%, high risk is more than 15%. If 5-yearly cardiovascular risk is low risk and there is hypertension, maintain lifestyle changes for 6 to 12 months. After 6 months, if blood pressure is still elevated, then consider drug treatment for low risk patient. For moderate risk, lifestyle modification for 3 to 6 months. Consider drug treatment if blood pressure more than 140/90. For high risk patient or someone like Aboriginal, someone having organ damage like hypertensive retinopathy, hypertensive nephropathy, you start drug treatment immediately. Clear? So that's why it's very important to know if this patient high risk or low risk. Depending on that, your start of medication will be varied. No, Dr. Voishi, ambulatory BP monitoring and Holter BP monitoring is not same. As already Dr. Rebecca told, Holter is for rhythm and ambulatory BP is for only blood pressure monitoring. Now we know that when to start treatment. So what are the treatment? Very important to know this. Initial medication is better. You can choose any of these three. So usually ACE inhibitor or ARB, especially if patient is more than 55-year-old, or calcium channel blocker or low dose thiazides. Usually if patient is more than 65, diuretics is good option. You can start any of these three initially. If you cannot get your target blood pressure after 3 months, then you can use combination. So with ACE inhibitor, you can use calcium channel blocker or thiazide or beta blocker. Again, in 3 months, there is no effect, then you can use 3 drug combination, ACE inhibitor ARB plus CCB plus thiazides. And last option will be spironolactone. Okay, so this is how you start medication in the patient. Now, this is important to know that which combination you can use. This is, let's see that this is a pie chart. This is ACE inhibitor, diuretics, beta blocker, calcium channel blocker. You can add any of these which is adjacent to each other. Like you can use ACE with diuretic with beta blocker you can use with it's not a good idea to use beta blocker and calcium channel blocker, so don't use this one. Okay, so in a normal person, I would suggest that you can start with ACE inhibitor or ARB with calcium channel blocker. So this one is good one. Best evidence is for these two combination. You can use ACE inhibitor with diuretics, ACE inhibitor with beta blocker. But try not to use beta blocker and calcium channel blocker because this will reduce the heart rate a lot. So relatively ineffective combination is beta blocker and ACE inhibitor. So A and B is not a good option. Similarly, C and D is not a good option. So that's why these two will not work. So CD do not combine, AB do not combine. Undesirable combination. So you should never use beta blocker and calcium channel blocker. Do not use ACE inhibitor and spironolactone together because it can cause hyperkalemia. Do not use ACE inhibitor and ARB because both of them are pretty much same. Okay, so based on what we understand, these two are the best combination, ACE and CCB, ACE and thiazides. We can use beta blocker, but it's not very, very good. So these two will be your good option to choose. Now, the last thing that we are going to discuss today is that someone having some coexisting condition, how we can initiate hypertensive medication for this particular condition, which is very, very commonly asked in the exam. Like someone having asthma or COPD. You should never use beta blocker in this patient because it can aggravate asthma COPD. So you can use others like diuretics, ACE inhibitor, calcium channel, you can use. Someone having bradycardia or heart block, never use calcium channel blocker or beta blocker. In cardiac failure patient, do not use calcium channel blocker if it's systolic. Someone having diabetes, do not start thiazide diuretics. Best for diabetic patient is the ACE inhibitor. Same with the dyslipidemia, do not use thiazide diuretics. Same with hyperuricemia or gout, do not use diuretics. For peripheral vascular disease, never use beta blocker because it can cause vasospasm. What is the best one? Calcium channel blocker because it can dilate the arteries. For pregnancy, do not use ACE inhibitor diuretics. You can use calcium channel blocker. You can use beta blocker. Mainly we use alpha methyl dopa. Someone having renal artery stenosis, this is very commonly asked. Now, in case of renal artery stenosis, if it is unilateral renal artery stenosis, best one to use is ACE inhibitor. If it is bilateral, do not use ACE inhibitor because you can precipitate renal failure. So you can use CCB, calcium channel blocker. Okay, so that's mainly what I wanted to discuss with you guys. Any questions so far? Yes, Dr. Hajra, the calcification was clear on the X-ray. You're talking about constrictive pericarditis, right? Now, one of the other topic is palpitation. We don't discuss palpitation in here. We discuss it in our ECG class. ECG class is very, very important and comprehensive, but it's for only our course students. So any of you who will join in our course, you will obviously get our ECG class. Usually we take 2 ECG class for your better understanding. So at that time, we will cover the palpitation. So that was all our class about cardiology. I know that I was going a little fast in hypertension. It's not very important and it's very boring. I know that's why I just wanted to finish this hypertension and wanted to show you what are the important things. If you open JAM, you will find a lot of talking, a lot of discussion, which you will feel sleepy during reading. But only thing that you need to know is this topic. So when we can start treatment, what are the treatment, and what are the specific blood pressure medication in some of the medical condition. That's all that you need. Now, in case of cardiac failure, Dr. Rebecca, it's better not to use calcium channel blocker. It's better not to use it in case of systolic heart failure. Because in systolic heart failure, what happens? Your heart is not contracting properly. And if you give rate limiting calcium channel blocker, it will reduce the heart rate. It will not pump enough. So it will just, you will just worse the condition. Now, the next thing for cardiology, so right now you know what are the things that you need to read from cardiology, right? So the next thing I want you to do, if you haven't finished our lecture yet, go through the lecture again. Even you can hear the recording. After that, read the JM at least once, solve the Q bank, which we will provide just after this free weeks session is over. And after you finish the Q bank, then you appear one of our mock test, which is cardiology mock test. In cardiology mock test, we haven't kept any ECG. ECG will take another mock test for ECG. So you can just finish this part and appear the cardiology mock test. When you do that, if you see that you're doing good in the mock test, then you know that you did good with this topic. So this is how we will make sure that you cover everything, every system in this way. Okay. So any question, guys? Any of you who is still wanting to join the 5 months course but haven't talked with us yet, make sure you send us a message or email so that we can start the processing. So thank you all. We will see you on when we are going to see you again. Let's see. I keep forgetting that. 9th of April. We'll do a cardiology question solve at this time. So we'll discuss some of the questions and we'll see that how it is helping after doing the theory. How can I contact with you? Dr. Shoikat, you can contact us through our email. I'll just write the email in your chat box. Okay, you can contact through this email. And if you want to know anything, then we'll be able to answer you. So see you on 9th of April. Have a good night. Bye.